Welcome, Professor.
How are you, sir?
Fine, sir. We are doing great. I hope you are in a busy schedule now in Germany.
Yeah, I'm in Germany at the German meeting right now.
Yes, sir.
Um, yeah, but I look forward to the session.
Yes, sir. We are also happy to have you here. We are all honored.
Great.
Actually, I just called Aip also. He was doing a surgery and he said he'll join soon.
Okay, great.
So we'll start in maybe 5 minutes.
Yes, sir. We'll start exactly at 4.
Could I ask you, Professor Kodaswaran,
Yes,
do you
sir.
want me to talk about acoustics at all or just discuss things?
Actually, we have 3 lectures by our Indian neurosurgeons. So we would like to have you as an inaugural guest. So we have to inaugurate the 750th year celebration. This is the first webinar. So we are going to have these kind of webinars for the next 1.5 years. So
Great,
our celebration starts from today.
wonderful.
So after the talk, we have 2 panelists, Dr. Sufiano and Dr. Paritosh Pandey. So we'll be happy to have your opinion about acoustics also.
Okay. So I won't plan to show any slides then.
Yes, please. We are happy to have your slides also. No problem. Please.
Okay.
So I am Matthew Abraham. I am the co-moderator. We would like you to have to give introductory remarks, and you can share slides also.
Okay. But just very briefly, is that the idea?
No issue, sir. Whatever it's
Whatever is
it's
fine
fine.
for you.
Okay. Okay. Well, maybe I can talk for about 10 minutes
Fantastic.
on, okay. Thank you.
That would be great, sir. That would be great.
Welcome, Dr. Manas, sir, Dr. Paritosh.
Yeah, good evening.
Professor Coolwell is there.
Morning.
Yeah, morning.
Hi.
Hello.
Manas sir will be speaking
Hi,
before
everyone.
Dr. Atul Goel, no?
Before, yeah.
Yeah.
He said he'll join later.
Okay, no problem.
Professor Borba is joining or?
Yeah, he's in Oxford now. He'll be joining in between. Some program is going on Oxford, Cambridge or Oxford in UK.
Okay. Should we check Professor Coldwell's share screen and our share screen? It's working or not?
Sure.
Yes, sir.
Good to see you, Manas. Good to see you.
Good evening, sir. Good morning for you, I think.
Yeah, actually, I'm in Germany right now, so it's just afternoon. Can you see that okay?
Yeah, yes.
Okay, great.
Можно записать, да?
Shall I share and check my screen, Cody?
Yes, sir. Please, sir, please.
Is it seen or no?
It's not seen.
Not seen. Not seen.
Maybe you have to change the window.
Is it seen now?
Yes, sir. Now it's seen.
Yeah, now it's okay.
Okay. Thank you.
Shall we start, sir? It's 4.
Yeah, yes.
Navneet ji, I want to share my screen now.
Yes, sir. Yes, sir. Please check, sir.
Yeah. Audition is muted.
Two minutes, sir. My system is not working. 2 minutes.
Okay. Okay, Tony, sir.
My screen is visible now.
Yeah,
Yes.
your screen is visible.
Sorry for the delay. Actually, some technical issue. First of all, I would like to invite all on behalf of Neurological Society of India, myself, Dr. Kodishwaran, Professor, Head of the Department, Government Kilpakumadi College from Chennai, my co-moderator, Dr. Matthew Abraham, Senior Consultant Neurosurgeon from Lisi Hospital, Ernakulam. So we, on behalf of webinar committee, we welcome you all. Today we have to have an excellent knowledge sharing session with the stalwarts from Indian and international community. So today the special event is we are going to inaugurate our 75th year celebrations of Neurological Society of India. We have two special guests from international community, Professor William Coolwell and Professor Luis Borba, who is going to inaugurate the session today. And we have three Indian stalwarts neurosurgeons who is going to talk about cerebellopontine angle tumors, the step forward, Dr. Aib Cherian, Dr. Atul Goyal, and Dr. Manas Panigrahi. And we have two panelists. One is Professor Albert Sufiano from Russia, and our Secretary General, Dr. Paritosh Pandey. I would like to thank Dr. Aib Cherian, who has connected the national and international community to have this webinar. A brief history about NSI. NSI was started in 1951 by Professor Jacob Chandy, Professor B. Ramamurthy, and Dr. Narsimhan and Baldev Singh in Chennai. And it has crossed various milestones. So it was started with 30 members from all over India. In 1952, Neurology India was started in first meeting in Hyderabad. Then the subcommittees were reconstituted in 1972. And CME programs were started on behalf of NSI in 1977. CME textbooks started in 1978. Our newsletter started coming from 1983. And the Progress in Neurosciences started from 1985. So this is the first professional society in India released stamp in 1999. Now we have a strong body with 4,000 members in the Indian continent and Asia. And our office team, Dr. Manas Panigrahi, President, and Dr. Krish Sridhar, President-elect, and Dr. Paritosh, Secretary General, and our Treasurer, Dr. Sumit Sinha, Dr. Girish, Journal Editor of Neurology India, and our past President, Daljit Singh, Professor Yadav and Kale, and our Executive Council members. Today we have two special guests of honor to inaugurate the webinar sessions of NSI 75th year celebration. Now I would like to welcome Dr. Matthew Abraham to introduce Professor William Coolwell.
Thank you, Kodishwaran. Professor William T. Coolwell serves as professor and chair of the Department of Neurosurgery at University of Utah. He has served as the director of the American Board of Neurological Surgery. He's a great leader in the field of neurosurgery. He was the president of the American Association of Neurological Surgeons, AANS. He was also the president of the American Academy of the Neurological Surgery, ACNS, and the World Academy of Neurological Surgeons, WNS. Professor Coolwell has more than 600 peer-reviewed publications and has been the recipient of several research grants. He's a keen researcher and innovator. Professor Coolwell is recognized internationally for his expertise in skull-base surgery and is a regular speaker in different meetings all over the world. His fields of interest include skull-base tumors, neuro-oncology, pituitary tumors, and cerebrovascular surgery. I would like to invite Professor Coolwell to give some introductory remarks for this webinar.
Well, thank you very much, Dr. Matthew. It's really an honor. And I want to thank Professor Kodiswaran for initiating this series. I'll share my screen if it's okay with you.
Yes, sir.
And could you stop sharing your screen?
Yes.
Yeah, very good. Great. Let me try again here.
Now you can share.
Okay. Okay, thank you. Great. So I thought it would be appropriate. Can you hear me okay?
Yes, sir.
Yes.
I thought it would be appropriate to talk a little bit about management of vestibular schwannomas, which are very common in the CP angle, and to talk a little bit about how we try to preserve nerve function and different techniques that we use. And so I'm going to take about 10 minutes First of all, congratulations to the NSI for the initiation of this webinar series. I have very many colleagues in India, and there's terrific surgeons there, some of the best in the world. And I've learned many things from the surgeons in India. And I think these webinars are a good example of the level of education that they're trying to initiate for all neurosurgeons around the world. So congratulations. And it's really an honor to be on the inaugural NSI website here for this webinar. This is where I'm from, in the hills of the Rocky Mountains and beautiful state of Utah. And the reason for that is because it's a safety issue. So the localization of hearing requires hearing in both ears. And you can see the Doppler effect and the directionality of the hearing. And so by preserving hearing, it's a safety issue, deciding which way the train or the bus is coming, and to avoid any injury. So it's an important safety issue, and I think it's underestimated. So this is a classic NF2 patients with bilateral vestibular schwannomatosis. But I think the treatment of schwannomas is evolving. And I would like to make the case that originally people start to lose hearing with a vestibular schwannoma. They'll likely lose it over 5 to 10 years. And it was originally proposed that radiosurgery might slow this curve down. But subsequently, this has been refuted. And the most recent literature in multiple studies has shown that the hearing loss with natural history or after treatment with radiosurgery is virtually the same. So I'd like to make the case that the only way to preserve hearing is if you can remove the tumor when the tumor is small, and you've got the best chance of preserving hearing with really good hearing. So our practice is that if patients are starting to lose hearing and they've got a small vestibular schwannoma, usually often presents to our ENT colleagues, then we consider removing it if it's feasible. And so I believe the hearing preservation and restoration will become more of a priority. So we use 3 different approaches. We're agnostic to the approach. I've done over 1,500 acoustic tumors, and the majority of them we remove with the translabyrinthine approach if hearing preservation is not a goal. If hearing preservation is a goal, we use either a retrosigmoid or a middle fossa tumor. And you can see the tumors that we use in the middle fossa. So I'm going to show you some of my technique that I use to try and preserve the facial nerve and also the 8th nerve when we're trying to preserve hearing. And I'll show you with this case here, which is a woman with hearing loss. She's 51 years old, but she's got good hearing, serviceable hearing in the left ear. And you can see this little acoustic tumor on the CT scan. She has a pacemaker, so she can't get an MRI. But there's her acoustic tumor, and she's got excellent hearing. And so I'll show you the operative video. And so what we do is we open up the tumor, obviously debulk the tumor, like the standard technique. And then I'm going to show you the technique that we use to lift off the tumor from the nerves. So if you have it down to a small capsule and you stabilize the nerve with a very soft cottonoid with your left hand or with your sucker hand, and then we just gently lift the tumor using a hook there. We lift the tumor off the 7th or the 8th nerve. And then we have to debulk the capsule more and complete removal of the capsule. So it's a combination of dissection of the tumor off the nerve and then removing the capsule as it becomes bulky and in your way. So this process continues until we go right up the internal artery and remove and there you have it. And we've preserved, in this case, we've preserved the 7th and the 8th nerve. And we do ABRs and we record the hearing function during the technique of removal. Here I'm waxing the air cells in the IEC that's been drilled by a retrosigmoid approach. We'll place a little piece of fat over this area. And then we'll wax the external cells in the mastoid, close the dura watertight, and then usually place a little burr hole cover or a small cranioplasty. So that's how we try to preserve the hearing. So this technique is different than the German technique, and I talked about this today at the German meeting. If you have the dissection along the course of the nerve, you'll be able to get a feel of how much the nerve is stuck to the tumor and decide how aggressive to be. But if we can, we like to remove the tumor completely, and that's our goal in every case. And then manage the tumor by reducing the bulk and then continue the dissection. And so you've got to find the planes between the tumor and the residual 8th nerve and the 7th nerve. And you start on the medial part of the tumor. We use these small dissectors, either hooks or a longer bladed right angle dissector, and find the plane and just lift the tumor out of its investment. And so that's how we do the tumor. Now we also, there's some anatomical variations that are important to understand. The IC is not uniform in every patient. It has different angle. And some of these IECs are angled more anteriorly, and the distance may be greater here between the sinus and the IEC. And then some of the IECs are more posterior angled. And it depends on the angle of this IEC, the visualization of the nerve through a translabyrinthine approach. So you can see in this particular case, you're coming along the nerve longitudinally, that you're not going to see much of it on face or on face, but if you come in this angle, you'll be able to see the nerve very well. And this really is more important and relevant when you're doing a translab approach. And so the visualization of the nerve may be different. Sometimes the IC is located very anteriorly, so you've got a long reach, whether it's retrosigmoid or a translabyrinthine approach. But let me show you a video showing two different views based on this angle. And so it might. Now we'll. So these are all considerations when you're using a translabyrinthine approach. I want to talk a little bit about the middle fossa approach because we do a lot of them. I do about 10% of my acoustics through the middle fossa approach, and it's designed for hearing preservation. This is William House, who devised it and popularized it. And I think the point is that we come in middle fossa, you identify the arcuate eminence here, the GSPN, which gives you a rough guide of where the internal carotid artery is, and you split that angle, and that's Brackman's line, and that's where the IC lies. And then what you want to do is you want to gently remove the facial nerve off the top of the tumor. This is the downside, is the facial nerve is lying on top of the tumor, but you're going to debulk the tumor and then lift it out from its investment. So I'll show you this in a video. And here's a middle fossa approach. Takes about an hour and a half to do. And I really appreciate doing this operation because it's really the best way of trying to preserve hearing in appropriately selected patients. So here's an intracanalicular CUS1 tumor. Patient's losing hearing. So we'll set the patient up with the head turned in this case, and right side, and we open up the incision and then identify the epidural approach, extradural approach, and I divide the middle meningeal artery, and then we'll drill over the IEC, identify the IEC, and then open up the dura over the canal. Now you've got to be careful of the facial nerve. It's lying anteriorly, and so we'll open up posteriorly in this case and move the dural flap out of the way, and then you see the facial nerve lying on top of the tumor. Now what you'd like to do is debulk the tumor and then lift the tumor out from its investment. So I'm debulking the tumor here, and then finding the medial aspect of the tumor and then rotating it up and lifting it out. Remember, the cochlear nerve is behind you. You don't see the cochlear nerve till the tumor's out. And then we'll divide the attachment of the tumor to the vestibular nerve, either the superior or inferior vestibular nerve, whatever it's attached to. Then remove any last bit of tumor from the facial nerve. And here you see the cochlear nerve. So the operation doesn't take very long. Put a little piece of fat in the IEC, fat in the middle fossa, fibrin glue, and then close. And this is the best way of trying to preserve hearing. Now, I want you to know that when we looked at these cases where we're trying to preserve hearing, some cases we weren't able to preserve, and it was always a mystery to me what the factors were that were important. And so we looked at the anatomy, and you need to look at the anatomy of the IEC if you're going to do this. So here you want a nice cap over the end of the tumor, so not too far into the canal. This is the cochlea at the end of the canal. If the tumor is approaching into the cochlea through the modiolus here, there's a very little chance that you're going to be able to preserve hearing. So it's the size of the tumor, it's how good the hearing is to start with, and it's the anatomy of the canal. Sometimes the cochlea is more lateral, adjacent to the canal, and you end up drilling it when you're trying to drill out the IEC. So we're inadvertently drilling some of these patients. We also do an MRI and look at the DWI signal because some patients have a high DWI signal in the 8th nerve. And we think that's an indication that the nerve may be adherent to the tumor, and the biochemical changes in the nerve represent a higher DWI signal. So when we look at this, and the factors of preserving hearing outcomes. In the early part of my series, I had about 75%, and in the later part of the series, I had about 80% hearing preservation. And I don't think I changed my technique. I think we are selecting the patients better. So patient selection is key. And the factors, you want good hearing to start with. You want to keep the blood pressure up because I think a lot of the hearing loss is vascular. And you want to look at the anatomy of the tumor in the canal to decide if it's worth trying to preserve hearing. Those are the factors that are important. So a high DWI signal in the cochlea, whether the fundus is overlapping the cochlea, and whether the tumor is touching the modiolus. These are all negative predictors of hearing preservation. So we can then develop a nomogram where we can look at a patient, look at their hearing preoperatively, look at the tumor characteristics on the scan, and decide if it's worth trying to preserve hearing with an operation. If we don't think we can preserve the hearing, then we might as well send the patient to radiosurgery in my mind, because that can stop the tumor growth, but it won't preserve the hearing. So hearing preservation in middle fossa versus retrosigmoid, we use intracannular vesicular Chalmers with Cruz 1s and tumor involving the lateral ISC. It's much better than a retrosigmoid for that. Good functional hearing, and the hearing outcomes are better with the middle fossa approach, but the facial nerve outcomes are better with the retrosigmoid because you don't need to remove the facial nerve from the top of the tumor. But the facial nerve weakness in a middle fossa is usually very minor, grade 2 face, that improves over time. So the importance of the tumor, hearing preservation, we use ABR monitoring in everybody, wide opening of the ISC so you don't compress the cochlear nerve when you're trying to preserve it, decompress the tumor, dissection medial to lateral, we give the patient nimodipine, and we watch the blood pressure very carefully.
This is about
We give dilute papaverin and then hydration for 3 days. So I think that hearing preservation will become more important over time. And the other thing that we're doing is we're preserving the cochlear nerve if we can. So if you have a smaller tumor, try to preserve the cochlear nerve, because you can put a cochlear nerve implant into a cochlea. Even if the patient's deaf, the cochlear nerve implant drives the facial nerve much more strongly than the native cochlea does. And so you can overcome hearing loss by using a cochlear implant in a large percent of patients. So try to preserve the cochlear nerve. And so I think that's the message I'd like to deliver, that we're getting better all the time at trying to preserve the cranial nerve function when we operate on vestibular schwannomas. And I think that we've improved a lot over the years, but there's a lot more to do. So I want to thank you all very much, and I'll stop sharing my screen. And I look forward to the other presentations.
Yes, sir. Thank you so much for your excellent talk. It's very knowledgeable ideas what you have given to us. Next, I'm going to introduce Professor Luis Borba. Navneet, can I share my screen?
Yes, sir.
Professor Luis Borba, one of the senior expert neurosurgeon from Brazil. He is one of our beloved neurosurgeon who has been mentoring us for a long time. And recently, he has achieved the topmost position of WFNS, President-elect, and Professor of Neurosurgery, Federal University, Parana, and was Chairman, Education and Training Committee of WFNS, and Chairman of FLANC. And he has delivered more than 200 lectures all over the world. And he was Chairman, Education Committee of WFNS in 2022-2023, and Secretary Treasurer of VANS, for the past President of World Skull-Based Societies meeting, and past President of Brazilian Neurosurgery Congress in 2014, past President Brazilian Neurosurgery Society in 2019 and 20. I welcome Professor Luis Borba for his special guest lecture.
Luis, are you here, buddy? Is Luis here?
Actually, he said join in 5 minutes.
Just send a message to him. I think he will join.
In the meantime, can you ask something to Professor Coldwell?
Yeah, please.
Yeah. No, it was very excellent points on preservation of the hearing during CP angle surgery. Can you explain why there is hyperintensity in the cochlea, and why does it is a negative predictor value in this?
Yes, that's an excellent question. We're just submitting a publication on that. One of our residents did a research year on that. And what we think is happening is that there's inflammatory mediators, there's induced by the tumor that are in the nerve and in the tumor. And these correlate with the DWI changes. And I think it's just making it more sticky to the nerve with those inflammatory mediators. So they're much higher in those tumors that develop DWI in the signal change. And so it's an indication, potential indication of stickiness of the nerve to the tumor. And I think probably relates also to the facial nerve. So these same factors are probably important in the dissection of the facial nerve. And as you know, in some of these acoustics, the facial nerve just falls off. And then other ones, it's impossible. Even if it's a smaller tumor, it can be very stuck. So it's definitely not predictable, but I think we're getting a better handle on these tumors that are going to be difficult to dissect from the surrounding nerves, which include the seventh and the acoustic nerve. So thank you for the question.
Professor Caldwell, Professor Caldwell.
Yes, Albert.
Yeah, possible question. What about your opinion about the brainstem implants for the restore the
For NF2, yeah, I think
you have experience, personal experience.
Yeah, we do a few, and I've done them. I did them many years ago as well, but we're doing more recently. But it's an okay response. It's nothing nearly as good as cochlear implant. If you can preserve the cochlear nerve, the cochlear implant is a very good option. It gives people some speech recognition so they can get open set speech, which is good, useful speech. The ABI is much more crude. It's more finicky, and it doesn't give you as good, reliable results. So we use it for NF2 patients, in those patients that are obviously deaf in one ear, and then if you remove the tumor in the other, they're likely going to be deaf. And so we use it in patients that normally would undergo lip reading. And so I think in those patients it has value, but it's never a home run like a cochlear implant could be.
Yes, thank you very much. Thank you very much. What your opinion about maybe future implants, future way for restore the hearing?
Yeah, I
Maybe
think that's
maybe other implants. I don't know.
yeah. I mean, I think the cochlear implant, the whole idea of cochlear implant has really come along in the last few years. It's been around for a while, but what we've realized more recently is that even if you're deaf with an acoustic tumor, if you can preserve the continuity of the nerve, the cochlear implant drives the nerve so much stronger than the native cochlea does that you can restore some hearing. So it's hearing restoration, even in patients that don't have functional hearing. So that, I think, and then the understanding of that and trying to preserve the cochlear nerve with your tumor removal. And sometimes you just can't. As you know, when the tumor gets larger, it consumes the whole eighth nerve, and it's very difficult to preserve anything. But if you can preserve the eighth nerve, then you give the patient a chance to regain some useful hearing in that ear. And I think that's the biggest indication. So it's interesting, Albert, because in America, the insurance companies don't pay for the cochlear implant at the same time as the removal of the tumor because they realize that everybody will be trying to do it. But what we do is we put a blank in the cochlea if we're there at the translab approach, and then come back a few weeks later and put the implant in. But so we need the system to understand that this is an important way of maintaining hearing, and we've got to get the payers to change their process. But that's just an idiosyncrasy of the American healthcare system. So I don't know if that would pertain in other countries. I don't know.
Thank
How
you.
many cases you have done post-excision cochlear implant surgery, and then are they happy or they have problem in synchronization of both the ears hearing?
No, yeah, it's not a problem. I mean, we work with ENT and all of our acoustics, and they've done probably 50 patients now of ours, where they've put cochlear implants into patients. We've removed tumors because we do a lot of tumors. We do about 80 a year. And so they've got a lot of experience now, and there's emerging literature showing that it's very helpful in a large percent of patients. So the key is to make sure that the nerve looks healthy when you're finished. It doesn't have to be functional, but as long as the nerve looks healthy and it's left in continuity and we preserve it. So when we dissect the tumor, we use techniques that make sure we don't pull on the nerve in the lateral part of the canal. We do the dissection from medial to lateral, so we preserve that communication with the cochlea. And so we're very attentive to the possibility of preserving the cochlear nerve so it can be used later, is the point. Okay, so it changes our surgical plan in some cases.
Can I ask one question to Bill?
Yes, sir.
Yes.
Nice to listen to your talk always. Just to ask you, how do you decide from if you go for middle fossa approach for small canalicular acoustic, how will you decide preoperatively whether it is arising from superior or inferior vestibular nerve? Because if it is arising from superior vestibular nerve, your chances of preserving hearing is much better. That's what I presume. You have any way to find out?
Yeah, so what we do, Suresh, is we look at the anatomy. So we do fine cut CT and see where the tumor is in the canal. So if the tumor is into the modiolus of the cochlea, if it's right against the cochlea, it's probably a waste of time trying to preserve the hearing, okay? But if we're going to remove the tumor, if we feel that we can preserve the hearing with decent chance, and as I went through in my talk, I think the key is in these patients is patient selection. I don't think it's that you're better in one case than the other. I think the tumor determines whether you're going to be able to preserve the hearing. It's these MRI features and whether the tumor goes to the end of the canal. So if it goes to the end of the canal, but there's still a little cuff between the cochlea and the tumor, that's perfect for middle fossa, okay? And we'll do superior or inferior vestibular nerves through the middle fossa. It's a little more difficult with the inferior vestibular nerve tumors, but we'll do them both through the middle fossa. And then the key is to just move the facial nerve away carefully. If the tumor is more medial, then we'll go retrosigmoid if we just have to drill a little bit of the posterior lip of the canal. So that's how we decide.
Thank you. Thank you, Bill.
Sure.
Dr.
And
Luis
then
Boba, yes, please.
in the cistern, we usually try to go retrosigmoid if we can do it, because getting the tumor in the cistern through the middle fossa is more difficult. Yeah.
Thank you, sir. Professor Luis Boba has joined. We welcome you, Professor Luis Boba, for your introductory remarks.
Louis was in Cambridge. He said he will join for 5 minutes and
Is there a join?
say hi. So I'm glad he's joined. And good to see you, Bill, Albert, Manas, and Professor Nair, Matthew, everybody, Cody too.
Thank you. I think he has
Thanks,
joined.
Art.
Professor Boba, you have to unmute your.
Yeah.
I'm trying to connect myself here, but I'm in Cambridge here, Cambridge lectures, and I use the phone. I think I have no connection to give a lecture, but I congratulate Dr. Manas, my friend Ip Shirian, and all the team for this wonderful meeting. I see here my friend Sufyanov and all the team, more than almost 100 people online. Are you hear me or not?
Yes, yes, yes.
Yes, yes.
The phone also is not working. It's crazy. See, we are undeveloped country. They are a developed country, but my Wi-Fi in Brazil is better than in England. One issue that I think we need to discuss when we talk about CP tumor is not only the surgical technique by itself, the indication by itself, that we already know and the results show. What's happened today in the world that is shifting the treatment. Today, many neurosurgeons that are not used to do a CP angle tumor, acoustic neuroma tumor, they are going there, biting a little bit, and sent to radiation therapy. It became the standard of care around the world. And more, many people is driving this and trying to say that it is the only way and the best way to treat. But the results show that the microsurgery is still superior in preservation of function and especially in long term. You see, if you give a radiation to a lady or a man with 30 or 40 years old, this guy has his entire life, 40 years, 50 years ahead. What's happening with this tumor? The tumor is dead or not? They will transform or not? You have malignant transformation, you have a new tumor that's coming. This you need to start to talk. Because it's very difficult to us. And the same happens with endovascular, but we are seeing now in endovascular more and more cases that is coming. They're supposed to be treated, and the aneurysm is coming back. And some meningiomas that we treat with surgery and radiation therapy, and now after 12, 15 years, there is transformation or the tumor is coming more aggressive. We need to start to talk about this, to talk about cure, not talk about control. Control is for malignant disease. For benign disease, we need to talk about cure. And vestibular schwannoma is a benign disease. We need to search, see, and work to get the cure, not only control that the word that they are using around the world. Okay, thank you very much. Opportunity to be with you. I'm very sorry here. If I get a better connection, I will come back. Okay.
Thank you,
I'm
Prof.
here. Yeah, close to the McDonald's.
Okay.
The connection in the McDonald's is better than the convention center. Imagine. Thank you, IP. Thank you, Manas. Where is Professor Atul? I want to listen to him. Yeah,
He's in a KM meeting, so he'll join soon.
Okay. Thank you, my friend. And sorry
Thank
for
you.
the.
Thank you, Professor.
Okay.
Thank you. Bye.
Thank you. Bye. IP. Ciao.
Thank you, Professor Luis Buba. So next we'll move to the talks for our main session. The first speaker will be Dr. Aib Cherian, my friend, my innovation partner, the Director of Neurosciences, Chitwan Bharatpur, and he is the founder of Sustainostomy, Ultra Micro Neurosurgery, and Neurosurgery Coach, and now is the Counselor General of ACNS, and he has innovated so many new concepts like exoscopes, robotic endoscope holder, and RF tumor ablation. I welcome Dr. Aib to deliver this talk.
Thank you, Cody, and all my friends. I'm seeing you online is great. I'm generally, I never go by PowerPoints, I show operative videos, but this concept, since I have just 20 minutes, I don't think I can do this without a PowerPoint. So I would just go ahead and show you what's the concept of this. And I remember introducing cystonostomy about 15 years back, or maybe much more, 2007, so 18 years back. And now, that time I remember the kind of looks that I got. So I'm going to tell something very, very, very radical. And I'm sure a lot of you will have raised eyebrows. Let's go ahead and talk about this. I'm glad Albert, William, uh, all of these guys are here, and Manas, and a lot of guys who's got extensive experience. I can assure you, I'm going to shake you all to the core when I say this, and I would like to hear your reactions as well. So I'm going to share my. Can you see my screen?
Yes, yes.
Okay, let's go. So we talk about CP angle tumor. So I'm going to talk about one simple thing. It's called the total internal decompression. It's not a new concept. It was followed by Walter Dandy for some time, but then since he did not have a microscope, it was just internal decompression. It was not total internal decompression. Now, Dr. Kono has talked about the capsule being.
Thank you so much.
Paritosh, I'm not done yet, so you can thank me after, buddy. So, uh, the total internal decompression, the concept is uh, very different. So, usually, you have a vestibular schwannoma, you have to have exposure, you have to get the dissection planes, you have to save the facial nerve, the cochlear nerve, you have to avoid vascular injury. You have a debate between total, subtotal, partial resection. Some people talk about radiosurgery, gamma knife. There's a region, some people even talk about if there is a partial resection, what is the region for partial resection? So the young neurosurgeons are all confused as to how we go about this. So when I was young, I I did not save any facial. I mean, when I started off, I mean, all my tumors were taken out completely, but the facial nerve was also taken out completely. Later on, I came to understand that the facial nerve needs to be preserved in a particular way. So I started dissecting the capsule in that particular way. And when I dissected that, the eighth nerve, was gone. Later, I started anatomically preserving the eighth nerve, but the hearing preservation was very difficult. So, about 5 years back, we started doing something which we got excellent results. If my uh, fellows are in here, they will tell you how um, I've heard Dr. Goyal talked way back before, just not preservation, but improvement of eighth nerve. And I was trying to look out how he was doing that. The only way you can do that, I believe, is total internal decompression. So let's look at the anatomy of the vestibular schwannoma. So you have your cerebellum here. You have the pia-arachnoid of the cerebellum. You have the brainstem there. You have the tumor there. The tumor is covered within, it's not the pia-arachnoid of the tumor, it's the capsule of the tumor, it's the perineurium. And then you have the nerve, and then between the capsule and the perineurium of the, between the capsule of the tumor, that is the perineurium, and the nerve, you have the vasa nervorum. This is in facial nerve, you can literally dissect this capsule away from the vasa nervorum without harming it. But any tumor beyond the size of 2 centimeter, if you dissect this capsule away from the cochlear nerve, then it is extremely difficult to preserve the hearing, although anatomically you may preserve the nerve. This is the this is the fundamental understanding with which we started total internal decompression. So generally, our plane is between the capsule and the pia arachnoid of the cerebellum, and then we try and find a plane between the nerves, and that is how we take out this tumor. So you dissect the capsule of the cerebellum, of the brainstem, and of the nerves. Now, what I would suggest is the retractor can be on this plane, but you need to get into the capsule. How do you do that? You break the capsule of the tumor till you see the yellow of the tumor. There is no bleeding in this plane. So you see the yellow of the tumor, you will see the different color of the tumor. You take a sharp forceps and you keep on dissecting. We just did one last week, and I'm sure Afsal and Suresh will tell you. You just keep on dissecting the capsule of the tumor. It is so called, it's very thin capsule. You dissect the capsule and give it to the cerebellum. Okay. And there is no bleeders on this plane. So you're going in here and you take the capsule and you are giving it to the cerebellum. You're not dissecting between the pia arachnoid and the capsule. You're dissecting in between the capsule and the tumor. So basically, once you dissect all that, then you dissect all that, you start decompression. Okay. You can decompress to an extent using the exoscope. You can decompress very thin, extremely thin. And this part I earlier used to drill the IAM. But if you put in a 30-degree endoscope, we are doing that routinely, and you can take off this entire capsule and even this large last layer of tumor, so much so that you can see the 7th, 8th through a membrane. You will see it through a membrane. You can see it clearly. You can put the stimulator and identify the facial nerve. You can see the 8th nerve, but it is through a very, very thin uh, capsule. I would not really call it the capsule. I used to think it was the pia, but it's not the pia. So this is what it comes to finally. Okay. So this is what I call total internal decompression. And it's a extremely safe, extremely easy technique. It just needs a radical shift in the mindset, because if you are trying to dissect this off, okay, then you're looking at not vascular injury at your stage, at expert stage, but definitely nerve injury. Not the facial, but definitely the 8th. So I would suggest, you ask me how much is your recurrence rate. I don't know right now, because I've started it only 5 years back and I was not convinced with it. Maybe about 30 cases we've done it for doctors, we've done it for lawyers. We have the evidence that the hearing, which was less, has improved with audiometry. The hearing has improved. In fact, for a couple of doctors, we have had this hearing, decreased hearing, which has improved later on. So even in cystic, this is very difficult to preserve the hearing. We have seen that it is possible. So it is a very radical mindset shift that I'm talking about. I would uh, I would want to know what is I mean, what is your opinion? Before I stop, I would want to show you a small video. Can you hear me? Can you hear this? Thank you very much. I would rather go to discussions and questions. I know I'll have a lot of them and a lot of criticism, but you guys can go ahead. And I'm sure I have made it quite clear because those cartoons I thought was very simple and very clear. Um, I would welcome questions, any
Yeah,
questions.
before Atul starts, I'll comment. It was a correct concept you told, Hype Cherian. What I have been teaching people, no, initially all we believed that these tumors are epiarachnoid in origin. Now we know that it is subarachnoid in origin. So whatever you are talking is, a subperineural dissection. It's the vestibular schwannoma's capsule is perineurium of the vestibular nerve from which the tumor has arisen. So what you have talked is total internal decompression. You are remaining under the perineurium, which is the capsule of the tumor from the vestibular nerve from which the tumor has arisen. And there is no arachnoid which separates this epineurium from the cochlear and facial nerve. At some point of time, we were all told there is arachnoid which protects. There is no arachnoid which protects this tumor from the seventh and eighth nerve, because these tumors now we know arise in the subarachnoid space, not in the epiarachnoid space. And as you correctly told, epineurium, which is a thin epineurium, it can mimic arachnoid. And how you differentiate it from arachnoid? You see blood vessels, which you correctly told, on the epineurium. You will not see arachnoid on the arachnoid. You will not see blood vessels on the arachnoid membrane. But my message also say young neurosurgeons, on the pretext of saving seventh and eighth nerve, you should never go for a subtotal decompression, which Professor Borba correctly told. And many a time you can take out the tumor in toto, and sometimes many a time you don't have to even go for subperineural. You can take out the perineurium also from the nerves. If the day is good, going is good, you can take it out totally. Subperineural dissection is when the tumor is stuck to these nerves. And thanks, Hype, you made the point very clear. Thank you very much, Hype.
Thank you, sir.
Thank you, sir.
So we'll have the discussion at the end. Now I'll welcome Dr. Matthew Abraham to introduce Professor Goyal, because Goyal is in the middle of some function of KAM, so he wants to finish his talk. I welcome Dr. Matthew. Dr. Matthew?
Am I audible?
Yes, sir. Please introduce Dr. Atul Goyal.
Okay. Professor Atul Goyal needs no introduction to any neuroscience audience at a national or international level. However, I'll go through these formalities. He's currently professor in Somaiya Medical College, Mumbai, formerly professor and head of the department of KEM Hospital, Mumbai. We all know he's a great innovator and researcher and has notable innovations in every field of neurosurgery. His original contributions are widely recognized in the fields of CV junction surgery, skull-based and vascular neurosurgery. He has described more than 200 techniques in these fields. He has more than 600 peer-reviewed publications and several book chapters to his credit. He has written very famous and well-accepted books even while he was a very junior neurosurgeon. He's a great teacher, leader, and you all know one of the greatest orators in academic field. He can hold any audience spellbound for any duration that he wants. And I must say that he has a gift to convey a message even while motivating people of all ages. He's a great surgeon, and maybe he may be having the widest possible range of surgical indications that he operates on. To keep it short, he's one person that all young neurosurgeons in the country would like to emulate. Professor Goel, please give us your talk.
Thank you, Matthew, for those kind words. And there's no question, I'm proud neurosurgeon. And I got beautiful opportunities to do what I do and what I have done in my life of neurosurgery. And I would now I will now discuss acoustic tumors in a different perspective from what you have been hearing me and what you have been used to hearing me for a long period of time. Acoustic neurinomas are very important neurosurgical material, and all neurosurgeons, no matter what, they like to operate on acoustic neurinomas. They develop their style of debulking, they develop their style of arachnoidal dissection, they develop a style of neurosurgery. And they grow into neurosurgery through acoustic tumors, and of course from meningiomas and gliomas and things like that. But acoustic neuronoma is a high-end neurosurgery, is a top-end neurosurgery. It involves techniques, it involves technology, but what I am going to let my audience hear from me today is that more than techniques, more than technology, it is the philosophy of neurosurgery that matters in entire world of neurosurgery in general, and acoustic neurinomas in particular. Acoustic neurinomas, we are used to seeing all varieties of acoustic tumors, and my department of neurosurgery at KM Hospital gave me such wonderful, great opportunities to do all kinds of, I don't have the count now as to how many acoustics I have done over the years, but it must be much beyond 1,500 numbers, which is a a number that I can be proud of. And many of these tumors, you see the vascularity of this tumor, and I will talk about the vascularity later, but just see the vascularity. It can be vascular, it can have a cystic outline, it can be extending across the midline to the other side, it can be multicystic in nature, it can be quite a nasty looking kind of a tumor. It has cystic components within the confines of the tumor. It can be small size, it can be big size, it can be reasonable size acoustic, and it can be bilateral acoustic neurinoma, as you can see here. So acoustic neurinomas are of various kinds, and I have to tell you one big beautiful sentence. We want this smile after operation. Of course, I am personally used to showing my technique as to how I do facial nerve dissection. I have been showing in hundreds of meetings. I have been showing in hundreds of meetings how I do my 8th nerve preservation, hundreds of meetings. And many of you are used to seeing my techniques and all. But today, I don't want to show my technique. I want to say that to do, of course, you have to do beautiful surgery and beautiful, but showmanship and surgical skills matter. But what matters is the smile. What matters is this beautiful smile that you have to give to these patients. Beautiful smile is what matters. And here comes a disaster. This young lady has, after the surgery, never smiled in her lifetime. She has never laughed in her lifetime, because if she laughs, she looks crooked and abnormal. She has lost her identity. She does not recognize her face. Her relatives do not recognize her. And she is in a miserable condition. Even if I have removed the tumor completely, even if I have removed the tumor, beautiful dissection I have showcased to the world of neurosurgery. And here comes another disaster. And I have to tell you, in my life of acoustic neurinoma surgery, I have got one suicide after surgery. See, the lady just committed suicide. I have got at least one divorce following surgery. And there was an attempted murder following demolition of the face. So one thing I have to give message to all the neurosurgeons of the world, of course, your techniques are beautiful. Of course, your techniques have to be paramount. But what matters in acoustic neurinoma surgery is one and only one thing is whether you are able to give a beautiful, good face to the patient. You must realize in all neurosurgery in general, but in acoustic tumor that we are discussing, your infinite potential to harm the person. You can damage the person. You can say, see my beautiful dissection, see my beautiful technique of facial nerve dissection, but there is a potential for irreparable and unbelievable kind of harm to these patients. We have to learn in neurosurgery to give smiles. We have to learn in neurosurgery to go, not do neurosurgery for ego and for pride and for showmanship, and to do surgery that so that I can show my dissection skills to my residents who are watching, show my dissection skills on the video. I think these kind of things are not valid and not good kind of a material that we should do. What we have to showcase is the beautiful smile. So in this perspective, I have to tell you how I have changed my life of acoustic tumor surgery. Now, this is one beautiful paper that you should read. In tumors more than 3.5 centimeters, 4 centimeters. There is some noise coming here. In tumors which are more than 4 centimeters. My answer to that question is you just cannot remove that tumor totally and save the face 100%. Your aim has to be 100% facial saving. And for that, in large tumors, my current concept is you do not dissect the facial. You leave a sleeve of tumor along the facial nerve. Don't even try to dissect the facial nerve because your skills are great and your skills are massive and your skills nobody can compare and you want to showcase your skills to the whole world of neurosurgery. But imagine the risk that is involved. The risk is far too big for a tumor, a benign tumor like acoustic. So this is my current concept. Now, here is the tumor, which is a massive and which is in variance from my earlier concept. I used to talk about this 10 years ago in a different fashion. Now, see this huge tumor, and there is a large tumor residue here. You can see significantly thick bulge of tumor. But this patient has completely normal facial nerve function. I will say that this is a fantastic result in this massive tumor. And if I had tried to remove this small, and I have a follow-up of more than 8 years in this patient who happens to be my driver of my car, no problem. He can hear from this ear. He has no facial nerve weakness, and he has never asked me any question about his surgery. And this is the residue. I think a phenomenal result. And this is what we should aspire for. My recommendation, which may be good, which may not be good, is don't try to tease the facial nerve from the capsule of an acoustic tumor. I know when I talk in this fashion, I look like little down. I don't look like a technical neurosurgeon. I don't look like a fantastic neurosurgeon, but I want to be the surgeon of my patient. Now, other thing is I had written for meningiomas. When we remove the meningioma completely, is the patient completely cured? My answer is not. You can never cure a meningioma. Simpson grading, I say I removed Simpson grade 1, I've removed Simpson grade 0, but this tumor will recur. So it is not, you can never cure a meningioma. Similarly, the bottom line of acoustic tumor surgery is you can never cure an acoustic. Remember this. So what we have to do is we have to remove the tumor radically. One thing is we cannot be conservative neurosurgeon if you want to, but in large tumors, my completely clear recommendation is, and I have no hesitation to say,
that don't please try to tease the facial nerve of the tumor capsule. It can be very good looking and good to show, but can be a disaster. In large tumors, you see this article, I wish that you read. In malignant tumor, I had written that we don't want to be technically sweet. We don't want to remove malignant tumor to showcase to the world, see what I did and what I have done. It is like throwing atom bomb on Hiroshima and Nagasaki. The whole world of Japan had disappeared at that time. The one who had designed the most fantastic technological wonder of the world, Robert Oppenheim, said, what nasty technique I used, what a nasty technology I used. And he had become almost like a wreck, psychological wreck after the surgery when he saw his disaster. Similarly, you do beautiful technical mastery on acoustic tumor. I have done hundreds, and after hundreds, I am telling you that don't ever try to show your technical mastery give the risk of facial nerve palsy. So this is what we aspire for. Don't worry if you have left some tumor behind. And believe me, if you have left 5% of tumor, and if you have left 20% of tumor, the recurrence rates do not matter. You realize that. Don't try to tease the facial nerve of the tumor capsule. This is my recommendation to all neurosurgeons. I know that I may not be. So if you are restrained in your approach, you are less likely to disturb me. This is what a girl says to the aggressor. You know, we have talked about technique, we have talked about technology all our life. How many people have talked about philosophy of neurosurgery? And this one great gentleman who all neurosurgery of India at least know him like and revere him in great respect and love. He talked about philosophy. Now about acoustic tumor, the thing is, it is not like meningioma. They are almost constant in their symptoms. They are almost constant in their clinical presentation. They are almost constant in their radiological features. They are almost constant in their surgical difficulties. And also the pathological variations are not too massive, like in meningioma, meningothelial, transitional cell, this, that, there are hundreds. Here, antennae A, antennae B, nothing more than that, little bit here. What matters is not the presentation and all. What matters is the outcome. And what matters in acoustic tumor surgery is facial nerve. So the other one bad tumor which I have realized is when there is fluid level in the tumor, these tumors are bad and nasty, and recurrence rates are very high in these tumors when there is fluid level in these tumors. So these tumors can be solid, this can be cystic. How you remove cystic tumor is a different. You know, cystic tumor, you open the cyst and you have the tumor. But to dissect the capsule of the facial nerve in cystic tumor is different. In necrotic tumor, and other thing is vascular tumors. So my experience, I don't know exactly the numbers which my department is working on, but I have worked on acoustic tumor for more than 40 years of my busy neurosurgical life. Another thing that we don't know, and what Suresh Nair also talked about, see, these tumors arise in the internal auditory meatus. And how they expand and how they take the dura of the canal, nobody actually knows. Epineural and perineural, which Dr. Nair uses often. This is a little bit controversial question. We have worked on acoustic tumor. I will tell you what we have come to conclusion. We have worked on trigeminal neurinomas. We have said they arise in the Meckel's cave and they remain within the confines of dura and confines of dura. We have talked about oculomotor nerve schwannomas. They arise in the cistern of the oculomotor nerve and they take the dura. They remain within the dura. We have talked about facial nerve neurinoma. They arise in the geniculate ganglion and they remain within the confines of the dura. We have talked about lower cranial nerve neurinomas that they remain within the confines of dura. They arise in the mastoid bone. Similarly, we have talked about C2 neurinomas. They arise in the ganglion and they have a very confined and defined kind of dural. On the other hand, in acoustic neurinoma, how they grow and how the dural relationship, arachnoidal relationship has been discussed by various people, including my friend Dr. Ohata. And of course, for a long time, Dr. Nair is talking about it. But my feeling is, I am not convinced that a lot of these tumor is covered by dura. So this is my feeling. And it arises in the canal and goes and takes the dura along with it. Now, if you ask me what approach I use, I have used lateral approach, this approach, all this mass middle fossa approach, as Bill Coldwell also said. But all my cases, whether they are small, they are big or what, except for very small, which they maybe possibly not need any operation, all my cases in retrosigmoid operation. Majority, a huge majority of my cases in sitting position. And many of you in the NSI audience in particular will remember, I did one live surgery workshop in my hospital from KEM, and I did 5 acoustic tumor from 9 a.m. to 4 p.m. 5. And they were all relayed live, and more than 250 neurosurgeons were attending that, all in sitting position. So sitting position is a position in which we meditate, in which we sing, and in which we are comfortable, and the patient is also comfortable. Of course, there are various nitty-gritties. You have to be experienced in this. Your anesthesia has to be increased. Regarding acoustic tumor surgery, my feeling is complete and my feeling is solid, and my experience, many of you in the world of Indian neurosurgery know that time, if I go beyond 1 hour, 1.5 hours in acoustic tumor surgery, that is a very bad and nasty day for me. Acoustic tumor surgery should be done in quick time. Debulk the tumor. Now, coagulation. Many of you have seen me doing acoustic tumor. Coagulation within the confines of the tumor is not necessary. Coagulation outside the confines of a tumor is a negative operation. It is a technical disaster, to say the least. Very small few points have to be coagulated, which of course I will discuss on some other occasion, where to coagulate in acoustic tumor, and not more than 3 or 4 times coagulation is necessary. And there is no, people can argue, people can discuss, but I can say positive, 100%. There is no need to keep on coagulating and go on for 10 hours and 15 hours in acoustic tumor. If you are going 10 hours, you are doing wrong operation. If you are dissecting the facial nerve for more than half an hour or 20 minutes, you will certainly kill the facial nerve. It is not necessary. Sitting position has, if you do long operation, if you take the surgery for a long time, it may not be a good operation. It gives you a possibility of lax brain, wide exposure, minimal interference with blood. I like it. In short, I like this position. You have to do constant irrigation, take care of veins, take care of, all kinds of venous bleeding from all over the place. And most important venous bleeding is the Gandhi's vein can come on the, if it bleeds, it should not bleed. Beautiful dissection. Debulk the tumor, and then hold the tumor and dissect the capsule, and then identify where the facial nerve will be. And now, as I have said recently, I don't dissect the facial nerve of the tumor capsule. People may say, oh no, I am more technical. Go and do whatever. But my target is one, and my target is 100%. I want to save the face of the person. I'm not saying that I save the face in all the people, even with my conservative option. But what you have to save, and hearing, many of you have heard me talking about hearing, and many of you have seen that hearing can be improved after surgery. Not many people have talked about hearing improvement. And I have shown on a consistent basis that you can improve the hearing, and saving the 8th nerve is easier than saving the 7th nerve. Of course, if lower cranial nerves have to be saved, if you cannot save lower cranial, then you should not do acoustic tumor surgery. If you have damaged the lower cranial nerve for more than 1 or 2 or 3 times, you should stop doing acoustic tumor surgery, no matter what you have done. I want to just show you my technique of, I have already told you, I don't like to showcase my technique, because I have realized that showcasing your technique and doing extra to show your work may be harmful for the patient. Now, I just want to show you, I have got a special technique of doing acoustic tumor surgery. This video, let me see if it works. Yes. Now here, now just see how I am, wait just a minute. See, this is the tumor. I have stopped drilling the lateral wall of the internal aortic meatus. Here you see on the right, this is on the right side, how I am delivering the tumor of the canal. You see this technique? This is a beautiful technique, but it needs special instrument handling, special way to hold the tumor, and you can hold the tumor and dissect upwards from the canal. If you are drilling the canal, maybe your facial nerve saving can be a little bit dangerous and may not be. So here is this is a different technique. You see how I'm holding the instruments. and how I'm dissecting the cranial nerve. I must tell you, this is a very old video of mine in one of the conferences where I showed this dissection. Now I don't do this dissection on the top of the tumor near the facial nerve. I just don't do it. And this is the patient. This is another case. I just want to show you if I can quickly, because I don't want to take too much time. But, you know, dissection of the lower cranial nerves, dissection, of course, lower cranial nerve is a different issue. But this is a different kind of dissection. Hold the tumor in one hand. You see the 8th nerve. And I have to tell you, and you have to believe me, not just preserving the hearing, but improving the hearing on a consistent basis on the most biggest of all tumors is possible. And somebody told me that if you preserve half the hearing, it is no good for the patient. It is not good. If you preserve little bit of hearing or half the hearing, it may just be very good for the patient. Of course, facial nerve handling, facial nerve dissection, we all learn with our, we have all different style of doing, different method of doing. We have to be proud of what we are doing. We have to be proud of our technique. But if we have to, you know, if we have to be proud, we have to be proud of one thing, and that is the patient's face. So in my journey of acoustic tumor, now vascular, this is of course not vascular. Even in the vascular tumor, most horrendous looking tumor, you don't have to coagulate too much. And that vascularity, you know, majority is not arterial spurters and things like that. Now the question about radiation. The whole world believes in giving radiation, gamma knife, this knife and that knife. My concept is clear. My concept is definite in my mind. And of course, the whole world may say what they have to say. But giving gamma knife and radiation to a benign tumor like acoustic may be indicated when there is a smallish little tumor and you don't want to operate. And if the person is not even fit for operation, my recommendation is operate, debulk the tumor. Even if it is recurrent, your aims and objectives remain one, and that objective is facial nerve preservation. This is a recurrent huge tumor, but you cannot say, I will damage the facial nerve in a recurrent tumor. You still do debulking. This after 10 or 12 years, this patient had come with ataxia. Facial nerve still intact. So I removed again a little miss. I left a significant part of the tumor behind. Significant when I say I don't feel ashamed. I don't feel, you know, subjected to maybe criticism, but my option is clear that radiation should be reserved for extreme. Radiation is not such a great thing for acoustic. This tumor, NF2, you know, NF2 is a different ball game. If you say I remove, I want to show you the facial nerve in NF2, it is a nonsense kind of a thought process. NF2, there are hundreds of tumors. You have to just be very conservative when to operate. This operation, my indication is ataxia. My indication is nothing else. If there is ataxia, this patient needs surgery. If this patient comes with hearing deficit, does not need surgery. Many of these tumors may be huge and they don't have ataxia. Don't touch them. Bilateral or NF2 is a difference. So my conclusions are, neurosurgeon should remember that you cannot cure an acoustic. And this is a beautiful, real message from a person who has done more than 1,500 and from a person who has whole life shown what technique and all those things. You can remove the whole tumor and nothing but the tumor, but tumor diathesis or ability to form tumor. So don't think that you can cure an acoustic. Don't think you can cure a meningioma. You remove radically, save the face. You remove, don't dissect around the facial nerve too much. You can dissect, and I have shown on several occasions in my life of neurosurgery how to dissect, how to do, and all those things. But today I'm saying the tragedy of facial nerve dysfunction is too big. After having problems with too many of my patients, I'm saying that recurrence of acoustic tumor is independent. This is a huge statement to make in acoustic tumor surgery. And I hope I am giving you a particular message that you do surgery, but don't try to showcase your technique. You have to showcase your patient. When technology surges ahead, this is what the message is. When technology surges ahead, the philosophy of neurosurgery should not lag behind. Every neurosurgeon should have a plaque in front of his clinic. There are some patients whom we cannot help, but there is none whom we cannot harm. Thank you very much.
Thank you, sir. It was an excellent talk as in your style.
Thank you. Thank you.
So we'll call our next speaker, Dr. Manas Panigrahi, who's a professor, HOD of KIMS Hyderabad, has more than 100 publications and its index of 26. He has completed more than 1,000 epilepsy surgeries. Now he is our beloved President, Neurological Society of India. I welcome you, sir, for your talk.
Can you see or?
Not seen, sir. You have to share your
You
screen.
just shared the screen. We had seen you sharing the screen, Manas.
Okay. Yeah, is it seen now?
Yes, sir. Please go on.
Yeah, thank you, Dr. Matthew, and thank you, Dr. Kodishwaran, for organizing the webinar, first webinar on the 75th year of formation of NSI. This will be the first webinar, and we'll continue to have like this webinar every month. After Professor Atul Goyal, it's very difficult to speak. He not only spoke the philosophy, but the techniques of functional preservation of cranial nerves. Um, uh, my topic is on factors affecting the cranial nerve outcome in large CP angle tumors, not the small ones. I'll be speaking how, in our experience of preserving cranial nerve function in tumors which are more than 3 centimeter size. The prognostic factors of both hearing, either hearing or facial preservation, are smaller tumor size or pre-op and pre-op hearing status. If the pre-op hearing status is good, they have a serviceable hearing, like they can hear, use the phone, then only one has to make an attempt to preserve hearing. Or if you have the facility of cochlear nerve transplant, as both Professor Goel and Professor Coldwell emphasized, that preserving the cochlear nerves is important so the cochlear transplant can be done. The consistency tumor also is very important. We'll analyze the results whether consistency of tumor is important in preserving nerve or not, and the surgical experience. I'll not talk about fifth nerve or lower cranial nerve, as normally the chances of damaging the fifth nerve or the lower cranial nerve are less in CP angle surgery. The first part of the study, what we did is of 320 cases from 2010 to 17, and we analyzed those 300 cases and to analyze what was the facial nerve function following post surgery and what are the factors which helped us in preserving the facial nerve. Out of the 320 cases, we excluded uh, 30, 34 patients because they already had a pre-operative facial nerve scoring of third to sixth. Only good ones, 1 to 2, 259 patients were selected for study. The routine monitoring was done, like standard monitoring during the surgery. And a few of the patients, we had tractography done to identify the facial nerve so that we are careful during surgery and we knew where to stimulate while operating the tumor. Uh, the facial nerve can predominantly is in this case the DTI is showed that it was anterior superior, and during surgery we found the stimulation anterior superior. We followed the similar technique what both Professor Goel and Professor Colwell emphasized, and Dr. IP also told. Professor Nair emphasized the following the epineurum and taking out the tumor, preserving the nerve. Facial nerve was, this is again another case where the DTI is sewed anteriorly, and during surgery also we found the tumor anteriorly located.
Dr. Manas, is your slides okay?
Yeah, but it's not moving.
The slides are not moving.
Not moving. Okay.
Mhm.
Okay.
Okay. Now that's fine. You're not put it in the full screen.
Is it moving now?
No, sir, make it a slideshow.
Yeah.
But slides. So you said it is not moving, no? Is it moving?
No, sir. Actually, it is not in slideshow now.
Yeah, not it in when I okay. Now is it moving?
Yes, it's moving, but it is not in
It's
slideshow.
So I think it's not moving. I don't know. That's what you. I'll
okay.
continue.
This is
with-
okay. This is okay.
Okay.
This is okay.
Yeah. Yeah. Now this is very rarely we find. This is again a tumor which was there and the DTI shows anterior-inferiorly. We reconfirmed during surgery that the facial nerve was anterior-inferiorly situated. Uh, Very rarely we found in 2% of the cases the facial nerve posteriorly situated. You can see here the nerve posteriorly located. Only could achieve in 26%. The perineural, if you had done a perineural, we had taken them as neototal, and we had when we had left removed only 95% or less, it will be taken at subtotal dissection. So we had neototal like it's 65% and 26% was gross total, and neototal was in 7.42%. And these are the post-op patients. These are large tumors, more than 3.5 centimeter. And this is we do a follow-up scan at 3 years and 1 year, and again every 2 years. Leave a little bit of fat in the IAC, maybe a little bit of tumor in the IAC, so that facial functional preservation of the tumor is better. This is again another case, post-op scan, leaving a little tumor along the facial nerve. There was a large tumor with preservation of the facial nerve function. This is again another neototal excision. The nerve, a little bit of tumor along the facial nerve was preserved to save the function. And this is a follow-up for 6 years. So even if the tumor was left less than 5%, we did not have recurrence. The recurrence dependent on the MIB index, what we published, that if the MIB index was more than 3%, then only they had a recurrence. Otherwise, we did not have recurrence. This is a patient with a large tumor where we had to leave facial. There's a large residual, but this patient on long-term follow-up had the residual has not increased in size. Of the tumors what we had operated, 5% were recurrent tumors and 95% were primary tumors. And most of them were median age group was 42 years. The maximum size what we operated was 59 millimeter with the mean diameter was 38 millimeter. So most of them were more than 38 millimeter size of tumor. The immediate post-op facial palsy, we had 87%, and after 6 months, they improved to 92%, grade 1 and 2. So this was a good facial recovery because functional preservation was important, but the excision rate was only 88 to 90%. 10% had residual tumor, but we had 90%, 92% good facial recovery. When we analyze the factors, gender or age did not affect, but what we found was right side tumors had a higher facial nerve dysfunction than the left side. I don't know, it has something to do with the handedness of the person. Probably I'm a right-handed, so I don't know, left side had a better facial preservation and functional preservation than the right side tumors. Nature of the presence of hydrocephalus, duration of symptom did not have any was not statistically significant, but cystic tumors had a higher facial nerve dysfunction than solid tumors. And as I told, most of our tumors were large tumors, and but still we could preserve facial nerve function. And when we did an ROC curve looking at the size of the tumor and the facial nerve preservation, what we found was 39 millimeter was the statistically significant. Earlier, it was taken as 3 centimeter is easy to save facial nerve. But what we found was even if it's 39 millimeter, almost 4 centimeter, one can preserve functional facial nerve without any difficulty with if you follow microsurgical dissection. The recurrent tumors, as recurrent tumors had a higher facial nerve dysfunction. So the primary tumors has a less 6.6% incidence of dysfunction post-op, where recurrent tumors had higher dysfunction. So in a recurrent tumor, probably it is better to be conservative in surgery and give them either gamma knife therapy, so that the functional preservation will be better. Of all the cases, we had only 3 cases where the nerve was posteriorly located. 7, it was inferior, and most of the tumors are anterior or anterior superiorly located. So when we analyzed with results of others, we had an anatomical preservation of 98% with functional preservation of 92% at the end of 6 months. And depending on the tumor size, if we had less than 2 centimeter, we had 100% preservation. And if it's 2 to 4, 95%, but it's more than 4 centimeter, also we had an 84% preservation of facial nerve. After attempting hearing facial preservation in our initial experience, we thought we'll start attempting hearing preservation. Now, hearing preservation, it is not easy, because the key factors for hearing preservation is one has to do avoid drilling, as Professor Goel was showing in the video, delivering the tumor like a pituitary, and so that there is no thermal damage, because what is published in this paper is when you drill, the thermal damage can cause potentially hearing loss. So if hearing preservation surgery is done, then avoiding drilling is one of the technique can be saved, can be practiced. And then cochlear, sometimes accidentally you can also drill off the cochlea. So cochlea also can be means one can, by avoiding drilling, one will not damage the cochlea and hence can preserve the hearing. So to preserve hearing, so we started avoiding drilling the internal auditory canal. So from 2018 onwards, we started doing excising tumor without internal auditory canal drilling. And as I was explaining, if one does drilling too much, then one can damage the cochlea. If one does too much posterior, it can damage the endolymphatic sac duct, and then that will again cause hearing loss. And if you do too much inferior, one can damage the jugular bulb. So excessive drilling of IAC can cause jugular bulb injury. It can cause hearing loss due to endolymphatic duct injury, semicircular canal injury, and one can have paradoxical CSF rhinorrhea because of the air cells. To reduce the complications, these complications, we avoided IAC drilling, and the primary aim was to preserve hearing in patients who had hearing preservation. And but we can see in the anatomical study published from PGI Chandigarh that the normal diameter of the IAC is the vertical diameter is 6.5 horizontally and 4 millimeter vertically, and it is safe to drill 5 millimeter all around. So if that is what, when the one does IAC drilling, we widen the canal to 1 centimeter or 10 millimeter. So if preoperatively, if the size of the IAC is 10 millimeter, already 10 millimeter, it is enlarged by the tumor, then probably it's not required to do IAC drilling. One can remove the tumor without IAC drilling. If it's only less than 10 millimeter, then one can safely do drilling. But if it's more than 10, it's not required, and then so that one can preserve better facial and hearing preservation by avoiding drilling. So these are the cases where the IAC was widened for more than 10 millimeters, so we did not drill the IAC. the same technique of facial preservation. So here, in addition to doing the technique of Professor Goel of delivering the tumor from the fundus like a pituitary tumor, we use the endoscope. Is the video seen, Dr. Kodiswaran?
Sir, seen.
Okay, so you can see here the complex, the vestibulocochlear complex, and the tumor in the fundus. So after taking out the tumor with the microscopic, deliver the fundus, we again use the endoscope, look for residual tumor, and take out. And then intermittently stimulate to confirm that there's a facial nerve and the cochlear nerve. So both the facial and auditory nerve are saved in this case, anatomically seen. And finally, the tumor in the fundus is removed. So this is the final bit of the tumor removed. But sometimes we might have to, a little bit of tumor gets left out in the fundus of the IAC. So what we try to do is we try to compare that whether doing without avoiding IAC drilling, whether our recurrence rate was higher because some part of tumor was left in the IAC. So we compared our results from 2010 to 17, then followed then 2018 to present, whether our recurrence rate has changed, has increased because we did not drill IAC. And also, we did all this technique in only 10% of the patient, because only 10%, 90% of 82% of the patient presented with hearing loss. So where we did not attempt hearing preservation, but only 10% had some hearing, and those cases only we attempted hearing preservation. And our mean size of the tumor was 3.8 centimeter. So it took the last 18 months, 47 cases we had operated. Out of that, 39 were more than 3 centimeter, and 11 had only preserved hearing, and the mean size was 36.8 millimeter. This is an example of a 32-year-old female with right side vestibular schwannoma. We used that perineural technique of saving the nerve, both vestibular cochlear nerve, and removing the tumor, the capsule in bits, and without disturbing the nerve. And preserve all the nerve fibers, is preserve the cochlear nerve, rather the hearing preservation is not the aim. To preserve all the nerve fibers is the aim. This is the suction irrigation technique which we published, and using a very simple placing an infant feeding tube with the shunt tube, and that works like a suction irrigation, gives a clear visualization between the nerve and the tumor. And this is again another large tumor. Large tumor also, we can see clearly the nerve and the vessel by using fluorescent. One can see here the tumor and the nerve has a very clear distinction, and one can do a perineural dissection to save the nerve. This is with normal light, and this is with the fluorescent, showing that the tumor is fluorescence, and with the normal tissue with the normal color. This is again brainstem with the tumor seen clearly. So here at the end, you can see again the vestibulocochlear, the auditory and the vestibular nerve saved at the end of tumor dissection. Of all the cases what we operated, the attempted hearing preservation of the cases, we had 44% where we could preserve hearing. And these are the audiometry of the patient pre-op and the post-op scan, showing that the hearing is preserved, though there's a little bit of deterioration in the higher frequency. The hearing preservation was better when it was less than 4 centimeter, but when it was more than 4 centimeters, still 2 out of 5 we could preserve, and in less than between 3 to 4, 3 out of 6 we could preserve hearing. And when we analyzed the first group 2010 to 17, where group 1 we were routinely practicing ISC drilling, and followed after 18 we stopped doing ISC drilling. We compared both the two groups. By this time we have almost 428 cases, and among the two groups, The first group with IAC drilling was 279 cases. We had 3 CSF leak with a recurrence rate of 8.9%. But without IAC drilling, we had no CSF leak because no paradoxical CSF rhinorrhea, and the recurrence rate did not change. It was 8.7%, though a little bit of tumor was left in the IAC. So the recurrence rate was similar, both though it was not statistically significant, but the recurrence rate was similar in both the groups. In conclusion, IAC drilling and its complication can be avoided. It is not mandatory if the IAC is more than 10 millimeter size in the pre-op scan. Endoscope assistance is a viable alternative for removing the intracanacular portion of the tumor. And recurrence of rate of vestibular schwannoma is similar whether one does IAC drilling or not whenever it is widened. And hearing and preservation, facial preservation seems better without IAC drilling. And tumor size till 39 mm is an independent predictor for post-facial nerve dysfunction. So till 4 centimeter tumor, one can preserve facial nerve function with excision, total excision of tumor. Thank you for your attention.
Thank you, Dr. Manas.
Next, we have two panelists. Now I welcome Professor Albert Sufianov from Russia. Dr. Sufianov is the medical director of Federal University of Neurosurgery, City of Tumen, and professor chairman of Department of Neurosurgery, Chinov First Moscow State Medical University, director of Education and Scientific Institute of Neurosurgery, People Friendship University of Russia. He has a great academic record and good, excellent neurosurgeon, and he was member of various academic bodies. Now I welcome Professor Sufianov to give his opinion.
Good day for everybody. Good wishes from Russia, from Siberia, from all my teams. I present the experience of my Federal Center of Neurosurgery and we stayed in Tumen. And at first, I want to congratulate the organizers of and neurosurgeons from India about this great webinar and this great topic about schwannoma, because it's really challenge topics. And also, personally, I want to say thanks to my friends Ayb Cherian and Luis Borba, Caldwell, and Manas, and so on for inviting me. Thank you very much. And about the topics and the lectures, and it's very interesting. I congratulate all our lectures about sharing experience, and for my opinion, there's a lot of VU we see now in this webinar. So Q, not Q, just only biting is very important, but it depends from the tumors, experience, and so on. So many factors involved. But in our opinion, we want to take as more as possible without with the fashion of preservation, of course. But in this surgery now, it's most important. It's very interesting to develop new devices. For example, hearing. It's very difficult to preserve the hearing. So we must to create the two options. First one is, in my opinion, is a preserve of hearing, and it's very difficult. And another topic is restore the hearing. And I agree with Caldwell, Professor Caldwell. Is now we must develop new way and new device for restore hearing. Is one of the most important way, not only surgery, for my opinion. And we must introduce more and more technical devices during the surgeries, like a laser, for example. For example, combination of the not only microscope, for example, not only endoscope, but is a hybrid technology, especially for the CP angle tumor. Why like this? Because, for example, if you use only endoscope for this kind of surgery, endoscope have a lot of blind corner, when you introduce endoscope inside of the CP angle, CP angle, sometimes it's difficult to move endoscope to see the good view. But if you combine with the exoscope, for example, like the IPS experience, IPS exoscope, for example, I think is a better way now. Better way than microscope, better when you along endoscope. So we must combine. We must need stitchless stream endoscopy, stitches VU of the angle. So combination of the, for example, exoscope and endoscope is, I think, is better and something like that. So it's my opinion about this great seminar. Thank you very much.
Thank you, Dr. Sufiana. Dr. Matthew.
Okay. Now our next expert panelist, Dr. Paritosh Pandey, he needs no introduction. He is our secretary. He is he's currently consultant neurosurgeon at Manipal Hospital, Bangalore. He is also adjunct professor at the Department of Neurosurgery, Manipal University. Previously, he was additional professor at Department of Neurosurgery in Advanced, Bangalore. He has completed his MBBS and MCH from All Day Institute of Medical Sciences, Delhi. He has a cerebrovascular and skull-based fellowship from Stanford University Medical Center, Stanford, and also an endovascular neurosurgery fellowship from Wayne State University, Detroit, Michigan. He is fields of interest of vascular neurosurgery and skull-based surgery. I must say he's a total, full spectrum vascular neurosurgeon. He has also taken leadership positions earlier, as he was the secretary of the Cerebrovascular Society of India and was an editor of the Cerebrovascular Journal of India. I invite Dr. Paritosh to give his expert comments on the topic.
Thank you, Dr. Matthew, for this kind introduction. So what we have seen is five people, five experts sharing their thoughts on acoustic neuroma. And one common thread that came out of all these things is the importance of functional preservation of facial nerve and, if possible, the cochlear nerve. And this cannot be more emphasized now, because when we were residents, it was given that the facial nerve will go along with the acoustic neuroma. So this is a sea change. And to hear experts like Dr. Goel, Manas, everybody to stress that you can leave a bit of tumor to preserve the facial nerve is something which is a sea change in the acoustic neuroma surgery. Of course, there are a lot of statements which have been made, which should be taken, which is based on very personal experience and not a large amount of scientific data, including for radiosurgery, because radiosurgery itself is a great technique for control of these tumors, for small and increasingly for large tumors as well. So what we would probably should have in the coming years is some good data, some good comparative data based on trials between various techniques, radiosurgery, surgery, subtotal techniques, and other things, so that the young neurosurgeon does not have to learn again and again. He should not start wheel again, and he should know what is the best way of treatment of many of these diseases. But the bottom line remains that the functional preservation of the nerves and the patient is paramount, and the all other metrics, which are gross total excision, anything else, is secondary. And this has been very nicely emphasized by all the surgeons, and I thank you very much to all the speakers for emphasizing this fact. Thank you.
Thank you, Dr. Paritosh.
Thank you, Dr. Paritosh.
Now it is open for discussion. Dr. Aib?
I mean, beautifully summarized by Paritosh there. One of the things that always confused me as a young neurosurgeon is how can I leave tumor? How can it look ugly on the scan? And we were always looking for the best results on the scan. That's how we started off. Call it ego, call it pursuit of perfectionism, because you show a result, and then people start laughing, and people are not very kind generally. I mean, at least 15 years back, people were not very kind. You show an image of partially excised tumor, it people talk about as if you don't know much. You just beginning and you don't know much, and so you had this thing to go ahead and sometimes hurt your patient, which is not correct. So I had to think out of the box to figure out in CP angle. I would any day clip an aneurysm compared to do a CPA because CP angle is manual laboring. It's literally manual, being a manual laborer. You have to go keep on doing, and if you're doing total internal decompression, you end up leaving the tumors in some pockets. Because unlike when you pull the capsule out, everything is coming out. And it's a very simple, you're not worried about the nerves, but you pull the capsule, and everything comes out. It's a beautiful result. But then at the end of the day, you have worsened your facial from grade 2 to grade 4. It may come back. You can say it will come back, it may come back too if you preserve the facial, but eighth nerve is gone for sure. So, and this is what prompted us to think like this. I mean, you should also understand the circumstances where we started thinking like this. And this subperineurial or the total internal decompression, I found it a very simple way. Stay inside the capsule, make it as thin as possible, use very high magnification, use exoscope with endoscope, and a lot of irrigation, no bipolaring. It's worked wonders for us. So I think it's a very easy way, and I think young neurosurgeons would also appreciate. And I see all the expert neurosurgeons in support of not going after the tumor and not showing a amazingly perfect scan. What is important is actually the function. Thank you very much.
Dr. Manas?
Now there is one question there on the chat box, that what about intracanalicular tumors with hearing preservation? I think that it was initially discussed by Dr. Coldwell that
Yes,
since
Professor
earlier it
Cole.
was thought with hearing preservation, it is means radiosurgery is better than the natural history. But then now they have realized that radiosurgery, the hearing loss is in 5 years, and in natural history, the hearing loss is in 10 years. But if you want to preserve the hearing without loss, it's better to go for surgery at the early stage. There is chances that 20% there may be loss of hearing, but 80% you can have preservation for lifetime if it's a small tumor. And I don't know others what can comment, Dr. Matthew or.
I felt that for an intracanalicular tumor, only if there is any progression or reduction of hearing should we try to change the natural history. Otherwise, many intracranial tumors with preserved hearing continue to have reasonably good hearing for a very long time. And the real difference that we can make may not be that great.
Yeah, but now there's a recommended guidelines come from CNS in 2025 Neurosurgery Journal. It's though not level 1 recommendation, but means if you at least operate, you can save the hearing for life. And if you leave it, means observation is better than radiosurgery for the hearing preservation. But then ultimately in 10 years, even if you wait and watch it, after 10 years, you lose the hearing.
Okay.
And radiosurgery, actually in 5 years, you lose the hearing.
Can I just ask the speakers one question? I'm audible, no?
Yes, sir.
Say, if you have a incidentally detected COOS3 tumor with normal hearing, no symptoms, what will be your approach, Manas? Incidentally detected. And patient is absolutely intact. Say, I am sure you are aggressive surgeon. You told 3.9. You can preserve
3.9.
facial, but
Yes.
hearing also is normal here, 3 centimeter. Just is just a candidate for gamma knife if you want. Will you wait for things to evolve, like a dip in hearing, or you go ahead, go and do something?
If it's a 3 centimeter, then I'll suggest gamma knife, because that will increase in size, and he'll have the natural history will be worse than the history of radiosurgery. Means in my hand I can only preserve 40%, so I'll not suggest surgery. Like I'll send to Coldwell, if he can save 80%, I'll send it to him. But in my hand, for this patient, I will suggest radiosurgery.
And Paritosh?
Yes, I agree with Dr. Manas. I would definitely I won't wait, because it's already 3 centimeter and it's been there for a while, so it will increase in size. It has increased from 0 to 3 centimeter, of course. So it will again increase in size. Less than 1 centimeter is a different ballgame. We can wait and watch and things like that. But 3 centimeter, it will wait. It will do again, and probably a radiosurgery is a very good choice for many of these tumors.
Okay, thank you. And I think Bill is there or not, I don't know.
He's not there. But what you will do, sir?
Myself, I will just, I will also agree with all of you. We'll go for treatment rather than waiting for his hearing to dip. And gamma knife only. Anyway, great seminar. I don't know anybody wants question. And Atul is there, right?
No, sir.
No, he's left. He's left.
Yes, left. Anyway, everybody ultimately concluded that it should be a nerve-centric approach.
Yes.
And not not patient-centric with nerve-centric approach. I agree, but at least Manas and Bill and others told that tumor can be removed near totally or totally, and subtotal removal if the tumor is stuck to the cranial nerves. That is what I also thought is the best option. Youngsters should know that many of these tumors can be removed in toto, and we can cure it actually. I will tell cure here. And this is vestibular adenoma is totally different from meningioma. Meningioma is extra arachnoid tumor. Always there is arachnoid to protect you from the cranial nerve. Here there is no arachnoid. Totally different ball game. But still, many of these tumors can be removed totally, what Manas has told. And that should be attempted. Otherwise, young neurosurgeon should not go with the belief that many of these tumors we should decompress and send them for adjuvant treatment, knowing very well that post-operative bleed in the tumor bed bleed is from residual tumor only. You leave some tumor, there is always a large chunk of tumor. Always there is a chance that it can bleed post-operatively. That's my comment. Great webinar.
Thank you, sir.
Thank you all for joining us. Almost we are coming to the closing time. So it was a great session by our international people and international people. I hope all of you enjoyed this webinar. We'll see you after 2 weeks in our next webinar. Thank you all for joining us.
Thank you. Thank you. Thank you.
Thank you.
And congrats, Dr. Matthew and Dr. Cody. You had a good attendance this time.
Yes, sir. 80 plus we had.
Yeah.
Thank you, sir. Thank you so
Thank you
much.
very much. Bye. Bye. Good night. Great day.
Thank you, Tripathi, for asking questions, and Dr. Tripathi from Bhubaneswar and Dr. Noor from Pakistan. We had a lot of international people this time.
Yes, sir.
Thank you, Manas.
Thank you, Manas. Thank you, Secretary General Paritosh, who is in the car, I perceive. Okay. He is driving. Okay.
Thank you, Professor.
Paritosh, you are driving. Okay.
Thank you.
Bye.
Bye.
Thank you. Thank you very much. Nice seminar.
Thank you.